Hello, everyone. We are talking about the digestive system, metabolism, and energy. We've talked a little bit already about metabolism and energy, but we'll touch on it a little bit more today. So here's our objectives. So, of course, how we get energy is through food. So we have to break down the food into energy into three phases. So the first one is digestion. That breaks down the food into subunits. Then there is glycolysis and oxidation. It takes the subunits, it enters into the cell and breaks down in the cytoplasm. So um, glycolysis, lysis, of course, means to break apart or, to splice or whatever. So glycolysis or glycolysis is the breaking down of glucose. So we first have to have digestion when we have our food, break it into subunits, and then we have glucose, or we have to break it down to glucose because glucose is what we need then to make our energy. So those subunits are then entered into the plasma or cytoplasm. So glycolysis is lysis of glucose. Oxidation then is conversion of pyruvate to ATP for energy. So glucose is then further broken down into pyruvate. Pyruvate then is broken down to make ATP. Remember, we talked about that. And the citric acid cycle is where we make even more ATP, which we've talked about a little bit before. So remember what we need, our chemical energy, what we're eating is made up of carbohydrates, fats, and others like proteins, those kind of things. And those are then broken down into ATP. This gives off heat. It also gives off CO2 and water. Water, we do need carbon dioxide, we don't. So that's a waste product. And then metabolism also generates heat. So that's why we're warm. So let's start with digestion. First of all, we have to ingest food. So this is the best way for us. If some people think, well, we could do IVs. IVs are not the best way to ingest what we need for our body. Um, we don't make things as well as our body does as far as breaking down certain things. Yes, you can give protein, carbohydrates, even fats through an IV, but those take a toll on the body, especially the liver. So people who have to have that kind of food, I guess you'd say, or IV nutrition, it takes a toll on the body. So it's not ideal to have that. So the best thing is to eat. So as we know, proteins break down into amino acids, polysaccharides break down into glucose, and fats break down into fatty acids and glycerol. So first we are going to put food in our mouth. That's where it enters the digestive tract. And in our mouth, it's going to break down the food into smaller particles by chewing. So we break it down into basically mush, I would say, unless you eat really fast, like I've known to do. I, this always brings up a memory of mine when I was at the hospital working and I got sick and they made me go down to the ED. And I don't know why, because I just had a stomach bug, but they made me go to the ED. And I told the nurse down there I was going to get sick. And of course, they had on the gurney with the side rails up. And I'm like, I'm going to get sick, And he couldn't get the barf pan, I guess it was emesis basin, quick enough. And I just threw up all over the floor. And I tell you, it looked like what I just ate. I swear to God, I'm like, I got to chew my food better. You can identify everything I just ate. So that's embarrassing. So chew down your food into small particles. It makes it easier for your digestive system to work. Saliva starts the breakdown of carbohydrates. So if you eat anything starchy or has a lot of carbohydrates, the more you chew it, it starts to have a sweet taste. So I've had things before where I've had students like chew on crackers, and if you chew on crackers for a while, they don't taste salty anymore, it tastes sweet, and that's starting to break down the carbohydrates into those sugars. So after we've chewed it up nice in the food in our mouth, then it goes down the esophagus. Um, it is propelled down to the esophagus or the stomach by the esophagus by peristalsis, so it pushes it down. There are two sphincters on the esophagus to prevent stuff from the stomach coming back up. So the first one is the upper esophageal sphincter, and that is the cricoid-pharyngeal muscle that kind of closes and then pushes food down. Um, that should make sense to you because the pharyngeal area is right up in the neck as well as the cricoid. So that is telling you that muscle is pushing food down. It closes when you breathe so that you don't get a bunch of air in your stomach. So that's helpful. You can't have air in your stomach. We've all had air in our stomach. That's why we burp. So, it's not the best thing about closing it. And you get air in there too when you swallow because you swallow some air along with it. The lower esophageal sphincter is the cardiac sphincter, and the lower esophageal is the other word for it. So cardiac or lower esophageal sphincter. And this is by the heart, of course, that's why we call it the cardiac sphincter. It prevents gastric contents coming up the esophagus. So this is where the food would enter the stomach. Now that your stomach sits right below the diaphragm. If you ever look at an X-ray, you'll look at where the diaphragm is, where the lungs go down to a point, and that's the diaphragm. And then right below the diaphragm on the right is your liver, on the left is your stomach. So if you ever see something in those areas that looks abnormal, usually, obviously, the liver will look white on an X-ray because it's very solid, whereas the stomach has gas, so it just looks like a big bubble of gas. Unless, of course, it's full of food, then obviously it's not. Or if it's decompressed from, getting the air out of it. So the hiatus is the opening in the diaphragm that allows the esophagus to come up to the mouth. So that's the hiatus. So it's just big enough for the esophagus to come up. That's important to remember. So the stomach is actually in different parts. There's different terms for different parts of the stomach. The cardiac part is where the sphincter is. That's where that lower esophageal sphincter is. The fundus is this upper part of the stomach. Then you have the body of the stomach. Then they have the antrum is here, and the pylorus is here. So there are two sphincters in the stomach. One we've already talked about, which is the lower esophageal or cardiac sphincter right here. And the pyloric sphincter, which connects the pylorus to the duodenum. So this sphincter right here. So you see that the pylorus and the antrum are very small portions of the stomach. The vast majority is the body of the stomach. The fundus is important when we talk about later. So there are hormones and neurotransmitters located in the stomach. So those are gastrin. This is located in the antrum and the duodenum. So it's located in that pre-pyloric area and then the duodenum. And this stimulates secretion of hydrochloric acid to maintain the acidity of the stomach. And the hydrochloric acid is required for gastric motility. It really breaks down those food particles so that when the food or whatever the stomach contents entering the intestine are a liquid form. You don't want them as a solid mass. That would be very uncomfortable. So it's a liquid form that moves into the duodenum. As the food or the whatever you're eating goes through the intestine, water is pulled out, especially in the large intestine, so that the food becomes more, or the waste material basically becomes more firm because we pull the water out. So if you had a colostomy and if you had it in the ileum, then it's very liquidy. If you have it in the colon, then it's more of a solid stool. Histamine, remember, this is made by the mast cells and basophils, and this stimulates the parietal cells. These are the epithelial cells of, inside the stomach, and they release gastric acid. And this, of course, again, is required for gastric motility, breaking it down into a liquid. Acetylcholine, this is made by the cholinergic neurons, and this stimulates release of gastric acid and increases gastric motility. So usually your stomach is just kind of sitting around waiting for food to come in. But when you need energy or you feel like a lower amount of energy coming into your body, then the cholinergic neurons start to send a signal to make acetylcholine so that it increases your gastric acid and it starts to get your stomach moving. That's why your stomach, when you're hungry, makes all those wonderful sounds that you're totally embarrassed by. But that is what it's telling you is, okay, I'm moving. Let's get some food in here because we need energy. Then there's the gastrin releasing peptide. This stimulates the release of gastric acid again, increases gastric motility. Somatostatin, it reduces reduces the release of gastrin and it slows gastric motility. So once your body is like full, on that Thanksgiving day that's coming up, once it's full, then we have somatostatin, which kind of slows everything down. It's like, okay, everything's out of the stomach. It's ready to move, and we don't need any more food. Ghrelin is where it increases the stomach to empty. It decreases when the stomach is full, and it signals the brain that the body is hungry. Pepsinogen is released by the chief cells in the stomach and is converted to pepsin, and it prevents the stomach acid from digesting the stomach tissue. Basically your tissues are made up of proteins, and so we digest proteins in our stomach, but pepsinogen protects our stomach from being food. What's that thing from Finding Dory? Friends, not food, right? Pepsin, it breaks down proteins into amino acids. So gastric emptying, what increases gastric emptying? Well, if you have a lot of food in your stomach, the stomach is going to try to empty it as best it can. So if you have more food, the more your stomach is moving and moving that food out into the intestine. Also, you have more emptying with high gastric acid because your body has told itself there's food in here that needs to be broken down, so you release more acid. So there's more acid in there to get it out, liquefy it and get it out. And also low blood sugar. Your body knows it needs energy. It needs that glucose. So let's move it along, right? So let's get it into the intestine so we can get it into the bloodstream. So that will increase gastric emptying. Decreases in gastric emptying, so when it slows everything down, is solids, fats, or non-isotonic solutions. So you'll see this with tube feedings, because it doesn't have things from the mouth that comes down to the stomach. You're bypassing a couple things there as it goes directly into the stomach. So when it goes in there, it's kind of slow. So this is why when we give tube feedings, we give them over a time frame. If you just poured it all in the stomach, it's just going to sit there like a lump, and that's not going to be comfortable. So we do it over a time frame. We never want to give like a great large amount and just let it sit in the stomach. We give it kind of as a drip so that it has time to move out of the stomach. Products of fat digestion, so a fatty meal, less likely that you're going to have gastric emptying. hypertonic or hypotonic gastric contents. So anytime you mess with the osmolarity, that's going to affect it. Emptying of low gastric acid. And because if your gastric acid is low, it's telling the body, it's telling the intestine there's not much in here, so I don't need to move it into the intestine. And then high blood sugar. We have plenty of energy. We don't need any more. So some of the stomach secretions, we have the hydrochloric acid. Hydrochloric acid breaks down the food. It kills bacteria. It converts pepsinogen to pepsin. So the pH in your stomach is 2. So it's very, very, very low. So it's very irritating. Um, and in the duodenum, it's needed to absorb ferrous sulfate or iron. So if you have low iron, the duodenum is where iron is absorbed. So it has to have that hydrochloric acid coming from the stomach, emptying into the duodenum, so you absorb ferrous sulfate. Pepsin is required for the breakdown of protein. We already talked about that. It is inactivated in the duodenum. So in the duodenum, you have an alkaline environment. So if you do, like you say, they say to do in nursing school, where you're checking the pH of gastric contents to determine if a gavage tube is in the right place, we are checking the pH. So a low pH is in the stomach, a higher pH is in the intestine. Now, the intestine is not like a high pH, it's still more of an acid, but it's more alkaline than what the stomach is. Gastric lipase, this is required for breakdown of fat. So um, it doesn't require bile like the intestinal lipase. So we start to break down fat in the stomach, and we use the stomach lipase or gastric lipase to do that. But once it's moved in the intestine, we also are breaking down fat, and we need the bile from the liver to help break down that fat. Lipase also is what comes from the pancreas, comes from the pancreatic ducts, and so it mixes with bile and it breaks down fat. Mucus protects the stomach lining from the acids. So when you vomit, God, this is a disgusting lecture. Anyways, when you vomit, you're like, wow, that pH of 2, that's just going to burn through the emesis basin, right? That's just so low. But it's mixed with stuff. It's mixed with the mucus and fluids or whatever. So it's not that low pH. Hydrochloric acid alone is very, very low pH. But once it mixes with stuff in the stomach, it's not as low as hydrochloric acid. So the small intestine has different parts as well. So you have for the small intestine, you have 3 areas of the small intestine. So the first part is the duodenum, and the duodenum is very short compared to the other parts. The duodenum is very, very, very short, but it's very important. The jejunum is the next part, and then the ileum is the last part of the small intestine. Where it connects to the large intestine is the ileocecal valve. So during this part, you have in the duodenum, this way is so important. The duodenum is, I would say, the major player in the small intestine. So in the duodenum, even though it's the smallest, the duodenum is where the bile duct is coming in from the liver. You also have from the pancreas the pancreatic enzymes. So, for the pancreas, there's 2 different types of endocrine cells. So you have the islets of Langerhans, that sounds like a movie, islets of Langerhans cells, and they secrete hormones into the blood vessels. So this is where you are getting that, where you're basically getting Insulin. Insulin is coming from there. Insulin basically comes from we have the beta cells too. That's where you're going to get those. Also, you have the exocrine. So exocrine has ducts. There are ducts from the exocrine, and that is secreting digestive enzymes, lipase, amylase, into the duodenum. And it's important to know that those are ducts, so those can become clogged. Remember that. So the pancreatic enzymes and the intestinal brush border enzymes and bile salts all combine in the duodenum to convert the food into smaller building blocks. So carbohydrates are converted to monosaccharides and disaccharides. Protein is converted to amino acids, fats to fatty acids, and monoglycerides. And water and vitamins and electrolytes are absorbed. And what's the big one from duodenum is iron. Iron is absorbed in the duodenum. So what vitamins are absorbed where in the small intestine? So in the duodenum and the jejunum, you have thiamine, which is vitamin B1, riboflavin, vitamin B2, pantothenic acid is B5. You don't hear much about B5, but it's important. Then in the jejunum alone, you have niacin, folic acid, pyridoxine, which is B6, pyridoxamine, which is also a type of B6, and pyridoxal phosphate, which is a coenzyme of B6. In the ileum, you're absorbing ascorbic acid, which is vitamin C, and cobalamin, which is vitamin B12. And throughout the entire small intestine, you absorb biotin. Also, some nutrients are absorbed into throughout the intestine: duodenum, calcium, magnesium, and iron. So some big players there are absorbed in the duodenum. That's why I think it's so important. Jejunum, carbohydrates are absorbed, fat-soluble vitamins, some water-soluble vitamins, amino acids, fats, alcohol, sodium, potassium, and water. In the ileum, you will absorb bile. So bile is back absorbed into the intestine. In the large intestine, we have the ascending colon. So the ascending colon is here. So you have right here where the small intestine connects to the big intestine is your ileocecal valve. Right at that juncture is the appendix, which is useless. It has no function. They think it's just a leftover of our, the way we've evolved, but it has no good function. It can obviously become inflamed or even infected. Then you have the cecum here, which is the very first part. And then you have the ascending colon. This is going up the right side of your abdomen. Then it will make a turn. This is the transverse colon. And then it comes down the descending colon on the left side of your body to this sigmoid colon here, and then into the rectum. So in the large intestine, we are absorbing water. That is one of the biggest things that the large intestine does is reabsorb water back into the body. But it also, whenever you're moving water, you're also moving some electrolytes because they always go together. They're friends, right? So you're absorbing water, you're absorbing sodium, you're absorbing potassium, some acids and bases as well. We do have some accessory organs in the digestive system. First of all, the liver. It produces bile and bile salts for fast digestion. It converts nutrients into the cell usable form, and it stores glycogen. So if you have too much glucose, your body converts it to glycogen in the liver and you store it there for use later on. When your body needs a pick-me-up, it will break down the glycogen and it will convert it back to glucose. In the gallbladder is where you store bile, and bladder is just a holding device, right? So your urinary bladder is just holding urine. Gallbladder is just holding bile. And then for the pancreas, you have your exocrine, which is pancreatic enzymes, and those are needed for carbohydrate, fat, and protein digestion. And the big one is fat. You really need those enzymes for fat, and neutralizes the fluid to raise the pH in the intestine. So glycolysis is where sugar is converted into pyruvate. Remember, pyruvate enters the mitochondria. Remember the mitochondria? Powerhouse of the body, right? So it's inside of the cell. Insulin first will be secreted from the pancreatic beta cells, and this allows glucose to enter the body, or enter the cell, I should change that, enter the cell. So once insulin attaches to the cell membrane, that is a gatekeeper to let in the glucose into the cell to be broken down into energy. So remember, it's located within the cytoplasm. It has an inner membrane and an outer membrane. The inner membrane is convoluted, and this is where you have your enzymes for cellular respiration. So pyruvate, the glucose is broken into pyruvate that enters, when that enters the cell, it gives off a total of 6 ATP, and that involves 10 biochemical reactions. So that's oxidation. So you get a little bit of ATP when it first enters into the mitochondria. So you have some reactions there, makes 6. Then it goes into the Krebs cycle. So you see here is your oxidation right here when you're talking about those processes to give you off a few ATP. And then you it goes through each of these. No, I'm not going to make you memorize this. I think that that would be mean and a waste of your time. You can always look it up. We just, for our purposes, we need to know that once glucose enters the citric acid cycle, it's going to make some things, but it's going to give off some things. So it does produce at least 30 ATP, kind of depends on the cell, kind of depends on what's going into it, but about 30 ATP. The big thing to remember is it needs oxygen to do this. You have to have oxygen to do this. When you add in the oxygen, you're going to give off CO2. Anaerobic respiration does not use oxygen, and that is not represented in the citric acid cycle. But remember, it only gives off 4 ATP, but you use 2 of those ATP to make the 4. So you're always like 2 steps ahead, 1 step back, 2 steps ahead, 1 step back. The problem is it gives off lactic acid, and therefore you have metabolic acidosis. So what are some issues with the digestive system? So these are just some common terms that you've probably heard before. Anorexia means you have no appetite, you're not eating enough, you don't want to eat, you have no desire to eat. Vomiting is obviously expelling anything in the stomach outside of the body, not a pleasant experience. Constipation, you cannot defecate. Diarrhea, that's all you can do is defecate. Loose, watery stools. So you're losing a lot of water with those stools. GI bleeding, obviously internal bleeding in the GI tract. Dysphagia means that you're having trouble swallowing, and gastritis is an inflamed stomach. Gastritis is a very kind of umbrella term. So if you come in, you don't feel good, your stomach hurts, you're vomiting, that's gastritis until we figure out what else is going on. So GERD, gastroesophageal reflux disease. So this is where stomach contents are refluxing into the esophagus. It becomes painful because the pH of the stomach is lower than the pH in the esophagus. So it refluxes back into the esophagus. And if it frequently happens, it becomes more and more painful. It can cause erosion, and it can cause, erosion to the point where you have bleeding or an ulcer formation. Over time, if it's not improved, then it can cause scar tissue to form and even have the tissue change, such as in Barrett's esophagus, where it's a precancerous change. So medications that we use, remember the medications we use just help with the acid. It doesn't help with the reflux. If you reflux, then you're always going to reflux. You just have a propensity to that, or you have something wrong structurally. But tell you the truth, I think almost everybody refluxes at some point in their life. I mean, if you haven't, it's coming. So, some of the medications don't, like I said, necessarily help with the movement of food, increasing gastric motility. So we have proton pump inhibitors, and this blocks proton pumps from transporting that hydrogen ion to where it needs to be made for the hydrochloric acid, and that inhibits acid production. We have H2 receptor agonist, and that blocks histamine from binding to H2 receptors, so it decreases acid release. We have antacids. Antacids are kind of a quick fix. They're basically a alkaline powder that can be either a liquid or like a tablet form, and that neutralizes the acid. It's a quick relief, but it's not long term. So if you don't get it frequently, maybe you've just eaten Thanksgiving, bringing up Thanksgiving again, eaten Thanksgiving and you've overdone it, and now you feel like, oh my gosh, everything's sitting in my throat. You can give the antacids, and that would help with that acid or that burning feeling. Prokinetics, they are given to stimulate increased gastric motility. These have some unwanted side effects. We used to use them a lot, but then we found out they have some side effects we don't really like, such as EKG changes, and some other things. So they are not prescribed very often, or if they are prescribed, they're prescribed for short periods of time. So maybe you're having, some stomach issues, like maybe you have a lot of burning in your stomach or something like that, and they give it to you once to kind of clear out your stomach to get things moving, but you don't typically take them over long periods of time. The only way to fix reflux, if you have like chronic reflux, the only way to fix it is a Nissen fundoplication, which means that you take the fundus of the stomach and they surgically wrap it around the esophagus. So when your stomach starts to churn, that muscle in the upper part of the stomach closes off the esophagus. It's a permanent thing. They don't reverse it. So you can imagine if you're sick and you need to vomit, you can't vomit because that is closing off the esophagus. So you're pretty miserable. So it's not something that they just jump and do. They used to do it a lot more. A friend of mine was having terrible reflux to the part her teeth were eroding from the reflux. And they put her on all kinds of medications. It didn't help. So they did the surgery, and then her abdomen got humongous, and it turned out she had a tumor in her colon, and that was backing everything up back in the stomach to the esophagus level. So they never did an upper lower scope. I think they did an upper, but not a lower. So they didn't know about the tumor. So now here she is, she's got that fundoplication done, and she can't vomit, and she really didn't need that done because once they removed the tumor, she didn't have that reflux issue anymore. So it always pays to do a little more investigating if you're going to go into something permanent like that. Hiatal hernia, this isn't the best picture. I picked this picture because it shows you the different types. Um, So here we see this is the diaphragm here, this line, and then you come in here, and here is the stricture. This is where your sphincter is on the stomach. It's right at that diaphragm. You have type 1 if you have a hiatal hernia, where that first part of the stomach is, comes through that opening, and so this is here. The problem with that is it's full of acid too, and it has trouble emptying into the body of the stomach. So you have this churning acid right here, can't really empty, so it's going to go up. It's going to go up the esophagus, and so that causes burning, pain. Type 2 is where you just have like the fundus of the stomach is now protruding through that area as well. And then you have where both, type 3, where both the top of the stomach and a protrusion is above the diaphragm. Quite uncomfortable. Gastrointestinal ulcers is where you have excoriated stomach or intestinal mucosa. The causes of ulcers, H. pylori, infection. This inflames the lining of the stomach. Once the lining of the stomach is inflamed, then it's more easy to injure it. So that acid that's sitting in your stomach will eat away at the lining. NSAIDs and other medications. So this is just a diagram of how NSAIDs actually hurt the stomach. And it's all having to do with NSAIDs are blocking prostaglandins. So prostaglandins are needed to keep the epithelial cells healthy. And if they don't have the prostaglandins there, you have gastric damage. I am not going to ask you all of this information here. You just need to know that NSAIDs can decrease the healthy biosphere, I guess you would say, of the stomach, and then they can cause gastric damage, and you have usually GI bleeds with those. Poor diet, also chronic stress. The more stressed you are, the more gastric acid, remember the cholinergic effect, the more gastric acid that you're going to be releasing. Smoking and alcohol use will also cause the pH in the stomach to change. Crohn's disease is a chronic inflammation of the intestine. They think it's most likely an autoimmune where the body is not recognizing itself, and so it's fighting against itself. There are risk factors. It tends to be genetic. They believe it has some environmental, such as smoking, and also your gut bacteria is not healthy bacteria. So you start out first here, you have the normal lining of the intestines, and then over time, this becomes inflamed, it becomes thickened, you have a mucus buildup, and then you start to get this fat wrapping around the intestine, and it becomes cobblestoned, and then you have the ulcerative colitis where it's become ulcerated in there, and you have what's called that the pseudo polyps because the surviving tissue is protruding out from the damaged tissue. Irritable bowel syndrome, this is a where you are going between constipation and diarrhea. The causes, they believe, is a brain-gut connection. Something's going on. Poor gut bacteria, severe infections that have caused the gut bacteria to be out of sync or not healthy bacteria, childhood stress, chronic stress and inflammation, or food poisoning can trigger it. Diverticulitis is sacs in the intestine. I was looking at pictures for this lecture and I'm like, oh my God, these pictures are disgusting. But anyways, it's sacs that form in the intestine. Obviously, this is a scope of the intestine. You see these pockets here. Those are called diverticuli, and they obviously can trap stool in there, trap other things, so they become inflamed and infected, and over time they can actually cause bowel blockage from scar tissue forming. Problems with accessory organs, you can have portal hypertension where the blood pressure in the liver is elevated, Hepatitis is inflammation of the liver. Jaundice is just a symptom. This is a buildup of bilirubin in the skin due to some kind of liver disease. So people say, I had jaundice. Well, that's a symptom of something else. You know, you have hepatitis or something like that that causes the buildup of bilirubin. Bilirubin is a byproduct of blood breaking down. And so when the blood breaks down, the liver filters out that byproduct and then it will bind it to or not proteins. Oh, yes, proteins. It will bind it to proteins, and then it will, once it's bound, once it's conjugated, it goes into the stool and then it's expelled from the body. But if the liver doesn't do that, then that bilirubin doesn't go out of the body and it goes into all the tissues. It's not just the skin, it goes everywhere, causes a lot of damage, but the skin obviously is what you're going to see the most, but it will cause damage into other areas like the brain and other organs. Cholelithiasis is gallstones in the gallbladder. Usually those gallstones are made up of cholesterol, bilirubin, and bile. They become very firm and they block the bile ducts, so you can't you can release bile, but it's not going to go into the intestines. So this is where you have the pale stools because the bile never made it into the intestine, or you have a severe pain, especially when you eat something fatty because you need the bile to break down the fat. And so you're in a lot of pain on the right epigastric area. Although that pain can radiate towards your back, to the side, even up into like almost a heartburn effect. Pancreatitis is very, very serious. It's an inflammation of the pancreas. So that is usually a hospitalization, unless it's a mild form, but most people are hospitalized with pancreatitis. Cirrhosis and ascites. Cirrhosis is a chronic inflammation of the liver causing scarring. And because of that, it affects your adrenal glands. So you have decreased aldosterone metabolism. So you have a lot of free floating aldosterone, and that activates that comes from the kidney, and that causes salt and water retention. So you're absorbing water. You also have decreased albumin, so you increase the oncotic pressure, so the water is now moving out of the vasculature. So it's fluid that's accumulating because of this liver disease. Causes of cirrhosis could be cancer, liver failure due to that hypertension, so you have portal vein distension. You also have portal vein distension from heart failure because the blood is backing up from the heart into the inferior vena cava, which goes through the liver, and that leads to edema. And then kidney disease, of course, too, because you can't get rid of the excess water, and so that leads to edema. Cholelithiasis, that's gallstones in the gallbladder. Like I said, they're made up of cholesterol, bilirubin, and bile. They block this duct right here. Pancreatic duct is coming in as well right there. So because of that, none of this bile, and bile is a lovely color. I don't know if you've ever seen bile. It's a very pretty green, but very bitter tasting if you ever vomit it up. But just a little bit trivia for you there. But you need that to go into the stool, and that's what makes your stool the color it is that green mixed with the brown or red from the blood cells. Intestinal obstruction, so you could have a hernia. This is where the intestine is protruding through the abdominal muscle. It doesn't usually hurt unless it's constricted or it's full of stool and then it becomes constricted. Torsion is a twisting of the intestine. This can happen at pretty much any time. Most of the volvulus I've seen, of course, is in peds, and we usually see that early on. So like the little kids will have volvulus. It's just the way that the intestine is laid in the mesenterium, the connective tissue. A tumor obviously will block the bowel. Paralytic ileus, so you have some kind of motor impairment due to nerve damage. And so then the bowel, you don't have the nerves moving the intestines, so it just sits there. So if it doesn't move, it just sits there and gives off gas, and that just gets makes the intestine get bigger and bigger and bigger, very miserable, and eventually it will rupture if you don't remove the gas. Infectious ileus, the infection causes the slowdown of the gut, and then everything just sits there as well. And then fibrous adhesions. This can come from surgeries. It can come from, endometriosis can cause it. Any kind of abdominal issue can actually cause adhesions. Intussusception is folding of the intestine. You have a telescoping. So it's not folding like you fold a piece of paper. It's telescoping. So you have here the ileum falls basically into the large intestine. So this is the most common place is right here at the ileocecal valve. Um, and when you look at an X-ray, you're looking for a couple of things. They call this the target sign right here. So it is where you're looking down on the intestine and you see the inner part is the small intestine folding into the large intestine, or this crescent sign as well. So that's where the intestine is also folding in there. This can be caused by polyps or tumors. You see it in small children as well. This usually can be fixed by putting gas into the intestines. So you are basically pushing out that folding of the intestine. If that doesn't work, then it's surgery. Post-gastrectomy syndromes. So you have dumping syndrome. If you look at gastrectomy, they're removing most of the body of the stomach. You still have the fundus, you still have the pylorus and antrum right here, but most of the body's removed, so it doesn't hold as much. So in that case, the food will move into the intestine much quicker because there's nowhere else for it to go. When it does that, it causes tachycardia, hypotension, weakness, pallor, dizziness, diaphoresis, diarrhea, weakness, confusion, and even hypoglycemia. Another thing is alkaline reflux. So the intestine is, since there's not much room here, it can't, if it's not going to go anywhere, the intestinal fluids will actually come back up into the stomach and into the esophagus. Afferent loop obstruction from a volvulus, a twisting, hernia, adhesions, also it can happen because of this surgery here. It's a scar tissue problem. Weight loss, that's usually why people are having the gastrectomy, but it can also cause malnutrition because you're not absorbing as much because maybe things are moving too past the duodenum, so you're not absorbing those iron and other calcium, magnesium. It can cause anemia as well due to the malabsorption. So these patients need to be followed very closely after they have this surgery. Childhood gastrointestinal disorders, imperfect anus is just that. You don't have an opening at the rectum. So obviously you're going to have surgery to fix that. Surgeries just depend on how much intestine and how close it is to the skin. Meconium ileus is where that first stool does not pass. Whenever you see meconium ileus, so if they don't stool within the first 24 hours, we start to worry about that. If they have a true meconium ileus, then we think about Hirschsprung's or cystic fibrosis, which we'll talk about in a minute. So failure to thrive, this is a very umbrella term as well. You have to dig into a failure to thrive child to see what the problem is. There's no disease called failure to thrive. That's just something that we notice the child is not growing. They have maybe some skin issues, maybe some developmental delays, and we want to see is what nutritional problem or what other GI issues could be causing it. Necrotizing enterocolitis is basically you see in the small children. I'm not going to go over it too much. It's rare. It is basically, they believe, some kind of autoimmune or some kind of immune problem. It presents like an infection, but they've never been able to isolate a bacteria that goes with it, so antibiotics don't help. Basically, they don't have like a lot of help. Usually it's rest of the bowel, possibly surgery to remove the dead bowel because it's necrotizing. And a high percentage of the kids don't make it. So it's kind of, and it happens really, really quick. So the first time you see bloody stools, I always tell my families, when we're discharging a baby, you see any blood in the stool, you bring them in. Most of the time it's not going to be necrotizing enterocolitis because you'll see a lot of blood with that. But we do want to make sure that we're following them. Cleft lip and palate is a structural problem, obviously. They have clefts either in their upper lip. You can have unilateral, bilateral. The palate usually is open. You can have cleft lip without the palate. You can have cleft palate without the lip. So it doesn't mean that you're going to have both. Can be genetic. Usually it happens very early on in development, and it must be surgically repaired. The largest issue with this is feeding. They don't repair it right away. They usually wait several months before they're going to repair it. I have this picture here because you see this part right here down below the nose. This sometimes will protrude upward, and so that is a problem. So usually before they have surgery, they will put like an appliance across this to help push it down into place. So when they do have surgery, it's in alignment. Another big issue with this is you have exposed mucous membranes, so they'll dry out. So sometimes you'll have to put some kind of ointments on those to make sure that they don't have that tissue damage. Esophageal malformations, tracheoesophageal fistula. So fistula, anytime you talk about fistula, is an opening between two things that shouldn't be there. The fistula is not a normal thing, and it won't close. So these are the 5 types of TEF. Type A, there is no fistula here, but there is esophageal atresia. Esophageal atresia means esophagus doesn't connect to anything, so it's just a pouch. These obviously you pick on very quickly because you try to feed them and it just comes right back out at you, but they don't have any respiratory problems because there's no connection to the trachea. Not super common. This one, the esophagus is connecting to the lungs, but the esophagus coming from the stomach is not connected to anything. So obviously, when they eat, it goes right into the lungs. It is super rare, so you don't see that one very often either. Anytime you feed them, they will go into respiratory distress because it's just going right into their lungs. This is by far the most common is this one here. You have the esophageal atresia where it's not going anywhere, but the stomach is connected to the trachea. In this case, you will see gastric contents going into the lungs, the little cough. The fluids in this mouth will not go anywhere, so they're constantly drooling. So you'll see that for this one and this one. For this one, you have the esophagus connecting in both places, extremely rare. And this is what we call the H type, where there's a small connection. And this one can be a little bit harder to pick up on because food will go down into the stomach, but if they reflex back up, it can go in here. If you see an X-ray on one of these, typically this where it has the pouch here, that you won't see any air in the stomach in this one or this one because it's not connected to anything that can get air into the stomach. Obviously, these 3 do connect to the stomach, so you'll see air. So if you put like a tube down into the esophagus and it curls, but yet you see air in the stomach, then by far that's going to be this one. If you see no air in the stomach, but you put the gavage tube down and it curls here, then that's this one. This one, if you see the tube go into the trachea, no air in the stomach, that's this one. This one is much harder to pick up on. Usually they have to have a scope for that. This one, again, tube would go down into the lungs, but you have air in the stomach because it's connected to the trachea. This is a disgusting picture, but I thought it was really good. This is pyloric stenosis. So here, the pyloric valve right here is stenosed, which means it's stiff. So it won't open, so food can go out into duodenum. So the food, as they swallow, just sits in the stomach. Well, it only will break down to a point, right? It's not going to be green because it can't mix with bile from here. It's only digested partially because that's all the stomach will do. So once it gets into the stomach, they vomit almost all of it back up and out because it's not going to go anywhere. And it either looks like just what they ate or it looks like something curdled that was in the stomach. But there's no bile, no bile. Buccal diverticulum, we talked about the diverticuli, with the pouches. This one is not like that. It is just it almost looks like a part of intestine that never formed. So that's what this is here, this diverticulum. It's congenital, you're born with it, comes off the small intestine, and it's just tissue left over from development. Most of the time, it does not cause a problem. If it does become a problem, it's because it becomes inflamed, just like your appendix would become inflamed. Hirschsprungs is where you do not have nerve endings in your intestine. Typically, that is in the sigmoid right here or in the descending colon here. So the stool, there's no peristalsis there. So the stool just keeps pushing and pushing and it just gets stuck in that corner. And then it becomes really enlarged. It doesn't hurt them because I don't have any feeling right there because there's no nerves. It does become a problem though when it keeps going on and suddenly nothing's going out. So now everything's going to go back the other way. And the stool that comes out is very, very, they call it ribbon-like very, very thin because there's nothing like pushing and dilating up the rectum. So we worry about this with meconium ileus when they can't pass that first stool. And they believe it's a genetic mutation that causes this. Cystic fibrosis, there's two things we worry about with cystic fibrosis is the airway and the GI tract. Now you can have patients with both problems. You can have patients with just the respiratory and their GI tract is fine or vice versa. So in the airway, we have a chloride channel. And as the chloride channel releases the chloride, remember chloride moves. Sodium always moves with chloride. They're friends, so they always move together. That's a salt, so water follows. So when you have this chloride channel releasing chloride, water is following it, and it will make your mucus nice and watery, and it will move bacteria and debris out of the airway. For cystic fibrosis, they don't have the enzyme to release the chloride. So the chloride is not released. So their mucus becomes very, very sticky, thick, thick mucus because the water is not moving that way either. And it traps all the germs and everything, but it's not going to go anywhere. So it's going to cause infections. So they don't have more mucus. It's just they can't get rid of what mucus they have, and that just builds up. So it appears like they have more, but they don't really have more. So that's the airway. Now in the GI tract, what happens is it is blocking the pancreatic ducts. So the pancreatic ducts can't get the enzymes, lipase, amylase into the GI tract, which is needed to break down fat. So therefore, they have these smelly stools because they're very fatty stools. The problem with not absorbing fat is you're not absorbing the fat soluble vitamins either. So they will have nutrition deficits as well. And they're just not absorbing what they should. So that's the GI problem. Celiac disease is also, they believe, an immune response to glutens. So it's like an inflammatory response, almost sees glutens as like an infection or an intruder. And so you have your stomach lining, intestinal lining here. You have the villi. The gluten comes in, it causes changes then to the tissue. Again, you don't have to memorize all of this, but you see how it's an immune response because your T cells are starting to disseminate and they are causing inflammatory response here. So you have your T cells and your beta cells. And over time, that causes the tissue to change. And the tissue is not healthy tissue. And when you look at it, it's this cobblestone appearance and it doesn't absorb like it should. Now, there is a difference between gluten intolerance and celiac disease. Gluten intolerance is not autoimmune. There's no damage to the cells. There's no biological markers that they found. Symptoms are triggered by consuming gluten and you just avoid gluten. With celiac disease, it is autoimmune. It does cause damage to the intestine. It's genetic, and symptoms are triggered with consumption of gluten, and you avoid gluten as well. These are just a few metabolic disorders in children. They're rare. Probably the most frequent one that you might see is PKU, phenylketonuria. That's where phenylalanine is not metabolized, so it will come out in the urine. Lactosemia, you cannot convert lactose to glucose. Fructosemia can't metabolize fructose, sucrose, or honey. Wilson disease, you can't remove copper from the body. Maple syrup disease is you can't metabolize amino acids. G6PD is where you have red blood lysis from medications, infections, or stressors, and that causes anemia, and it also causes increased bilirubin in children. Like I said, these are very, very rare. Each state has their own newborn screening to pick up on these disorders, and they take the blood drops and they put it on the paper. There's like a card, you put that on the card, and then you send it to the state and they will run it. And it's, again, remember, it's a screening, it's not diagnostic. So if it comes back abnormal, then they need more testing. So that is all we have for now. And if you need anything, please let me know. Have a great day.